Good evening. I know we have several people still joining, so we'll just hold off until we feel like most people have gotten into the presentation. I'll usually give it till about 7:02 to start. That way it gives everybody a chance to log on. All right. Well, good evening, those that have had a chance to join already, and we might get a few more joining. My name is Dr. Paige Harrington. I work with Vets Pets as a Vice President of Medical Leadership, and I'd really love offering CE to those in our referring community, and sometimes we get somebody from out of state join. And tonight we have Dr. Elizabeth Taylor joining us, who I am very appreciative of because she had just came out of a 4-hour long humeral fracture and probably rushed that closure so that way she could come in. And I'm sure it's all been a very busy day, and we're very appreciative of her being able to join. Couple things before I introduce Dr. Taylor officially. If you have any questions, go ahead and enter them into the chat. And then that way I will be able to monitor that. If I feel like it's a question that really pertains to the slide that we're on that might help clarify something that might be confusing, I will go ahead and interrupt Dr. Taylor. If not, I will hold questions until the end. So just go ahead and put them in, and I'm monitoring that, and we'll kind of figure out the right time to go ahead and ask Dr. Taylor that question. For those that have not attended before, we will send you your CE certificate in the next week to the email address that you signed in on. And also please plan to join us on the last Tuesday of July for a discussion with Dr. Shannon Bass about moral injury. I've listened to that talk before, and it brought up some really good points about our profession and our jobs. And I walked away having some tools in my toolbox to deal with some of the things that we face every day. So Dr. Taylor, thank you again for joining us after a very busy day. Love to introduce you. I had the opportunity to work with Dr. Taylor for a couple of years, a few years ago in Wilson, before she moved to Wake Veterinary Medical Center in Nightdale. And she is very easy to work with, very understanding that our days are busy and that this is her expertise, and she's happy to take these cases on. I'm really happy that you're presenting this to us, because we all have those cases that you think, I know this isn't for me, but I need to get it somewhere else. But how do I make it look like I know what I'm doing before I do that? So this will be a very helpful talk for that. Dr. Taylor grew up in California, and she is double boarded in small animal and large animal. She obtained her large animal, or she went to Kansas State for her large animal residency, and then worked on her small animal education here in North Carolina, and became boarded in, I'm going to say 2018.
18. Mm-hmm.
Okay.
Yeah.
Yeah. Dr. Taylor lives in Raleigh with the cutest little twin boys you've ever seen. And Roger, I think, is a very sweet dog that she rescued from Eastern North Carolina, who now lives the high life. Roger, he works every day, very, very hard.
Very hard.
So thank you, Dr. Taylor, to present here tonight, fracture management prior to surgical referral. Again, if you have any questions, go ahead and put them in the chat, and I will be monitoring that throughout the talk. And I'm going to go ahead and mute myself and turn my camera off and turn it over to you. Thank you, Dr. Taylor.
Okay, great. Well, first off, thank you for having me. I'm very excited to give this talk. Yes, I do quite a bit of orthopedic surgery here at Wake Veterinary Medical Center, and always very appreciative of your referrals, and happy to speak with anybody on the phone. And I will reiterate that towards the end. But basically, I kind of wanted to make this more case-based. It would be really amazing if we were in person, but hopefully through the chat we can do some of that, and I'm happy to kind of answer some real-time questions as well. The goal of this presentation. Can you see? Okay, good. The goal of this presentation is really just to kind of set patients up for success, set you up for success, set me up for success, set the patients up. It's whether you work emergency or general practice, you're probably going to run into some of these cases. And we want to make sure that by the time it gets to me, if it does need surgery, that we are pretty much good to go, and we're not doing, I guess, any more harm than is already there in terms of the fracture. it's oftentimes, I think, a very charged time for the owner. So trying to keep them as relaxed as possible, especially when they're, looking at a pretty, financially charged situation as well. So I just kind of want to walk through. So today we're going to talk about really the objectives of this talk. We're going to walk through some things. So pretty much a evaluation of the entire patient. Can't stress that enough. That goes without saying, especially when we're talking about dogs that are hit by cars or experience some major polytrauma. But we still want to do that, even if we understand, that maybe they jumped or maybe they did something. I think this also comes into light when we talk about fractures where we can't necessarily get to the bottom of the injury, and making sure that we are doing a good workup, because definitely we do see some of those pathological fractures that come into play. I can't stress this enough. We'll talk about it, importance of good orthogonal radiographs, and sometimes additional imaging. Would I love to have CT on certain pelvic fractures? Yes. Do I understand that, in terms of financial constraints? Is that always possible? No, it's not. And so a lot of times we have to do other things, or maybe submit the radiographs for a radiologist to review. But just making sure that we're not sending one radiograph. That is very, very challenging to give an appropriate idea of what the owners are looking at. And then we're going to spend the bulk of the time. I'm going to basically just go through cases and talk about kind of the key principles of fracture stabilization before referral. I've got quite a few videos on bandaging, how I bandage, how I like to make my own splints. I think that's extremely helpful, just given the gamut of surgical patients or any patients that we see. I mean, we see anything from 2.5 kilo dogs with radius ulna fractures to 64-kilo dogs that have femoral fractures and anywhere in between. And we want to make sure that, if we are going to place a bandage, we're placing it properly, what that looks like. And then very brief, but just kind of improved communication and coordination with owners and kind of surgical teams. Our goal here is to get a fracture in as soon as we possibly can. That being said, there are some fractures that are more emergent than others. And so if you're delayed a few days, that may be why. It's not that we can't get them in. It's that honestly, if we stabilize and can get that, I can still fix the fracture in a timely manner and have a good outcome, even though it's not an emergency. Okay, so evaluation of the patient. I think this is a big one. Mechanism of injury, hit by car. Obviously, we want to evaluate trauma to other body parts. So predominantly the thorax and abdomen. I think a big one that goes overlooked a lot of times is the assessment of nerve function. I think, even myself included, brushing up on a neurological exam. It can be challenging in these patients just because they are painful and we may have to do some other things before that, but making sure from a nerve function and vascular status that we are stable prior to referral, and prior to kind of working everybody up for a fracture fixation. A hit by car is probably going to be treated or triaged a lot different than a dog that had a fall. And then going back to the point of potentially a pathological fracture, sometimes we have to dig a little bit deeper, and that, not all osteosarcomas come in with a very large moth-eaten bone. Sometimes it's a weird looking fracture. It may have some punctate lucencies. I will say myself, I have been fooled before and fixed a fracture that was an osteosarcoma, and it stinks. And I, still think of that case to this day. But, keeping that in mind is that if there isn't, a great reason why this patient sustained a fracture, how are we going to look at that differently? How are we going to, work that up, figure it out? And then talk about, open versus closed fractures very quickly. We'll look at a few cases and what bones are more likely to be open, which I'm sure anatomically we all know, but just making sure that if, even if there is a question of whether or not it's opened, I would prefer, starting on antibiotics, rather than not, just because it does put us quite a bit behind the eight ball if it is open and we haven't had that opportunity. Even that being said, I would probably, culture at the time of surgery, and then we'd kind of go from there, but that definitely can affect some healing time. All right. So minimum database, physical exam, I think neurological exam, again, I kind of mentioned, don't underestimate the importance of this. It is challenging to do, especially in a pelvic trauma where they're not walking as much. But again, I would say the two probably most important fractures that we'll see that do need a neurological exam would be a humerus fracture and a pelvic fracture. And we'll go into a little bit more detail when we get to those bones. CBC chemistry, I think we all know that. I'm going to show you, there's a paper out there mainly for femoral fractures that talks about some excessive bleeding and in those types of fractures, so something to be on the lookout for. And then in terms of chemistry, a lot of these patients will have some singular elevations in ALT. Sometimes I think people potentially may be afraid to manage those with non-steroidals. Just want to make sure that we are doing appropriate pain management in these, and we'll talk about that a little bit as well. Radiographs, stress that, and we're just going to get into that next with orthogonal views, and then plus or minus abdominal ultrasound. Again, when we get into kind of evaluating other systems, especially hit by cars, making sure that your bladder is intact, there isn't any hemoabdomen or other sort of intra-abdominal trauma. Definitely chest radiographs if you suspect potentially a pathological fracture, and then again, probably a hit by car or any sort of big, potential trauma, pulmonary contusions, pneumothorax, things like that. Okay. Importance of pain management. I think this kind of is a segue for me into those good orthogonal views. These patients are painful. We want to make sure that in order to obtain good radiographs, these patients need to be sedated. So yes, again, that does speak to stabilize your patient first. If they're not stable for any sort of sedation or anesthesia, that may, radiographs can wait, the fracture can wait, the patient is of the utmost importance. But we do want to provide a multimodal approach. We're going to use non-steroidals. We're definitely going to use opioids. We potentially may do a CRI. There are cases, that they are so painful do we need to think about doing something like alfaxlone, where we can get them to an appropriate plane in order to get a good radiograph. That is for me, whenever I get a referral for a fracture, it is my first question. Do you have the radiographs? And that just is very, very helpful for us to guide what the next steps are. So this is why we talk about orthogonal radiographs. So this is a humerus fracture. It looks it looks fairly innocuous at this point, maybe a, lateral condylar fracture. This is not the one I did today, but it is very similar and it's stressing me out. So I might have PTSD tonight, but so, then we take the orthogonal view and then we see this. So again, this is a much different fracture, a much different thing to prepare the owners for. So this is whereas a lateral condylar fracture, surgical time is not that long. This is going to be a much more intense, a bilateral approach for me, a much more hardware. So I'm going to try to put as much hardware in here to stabilize it because it is the humerus. So just from a lot of standpoints, this is a much different look. So having that orthogonal view is very, very important. Any questions on that so far? In the sake of time, I didn't get to add another example of that I thought, but we're going to move right into bandaging. So bandaging and splinting. So goals behind that, wound management. We kind of briefly talked about that in terms of if there's open fracture, but sometimes a lot of these can have some abrasion. So making sure that we keep those covered, definitely controlling edema. That's super important. I even a lot of times in certain radius, ulna, and certain tibia fibula fractures will place a post-operative bandage just because it does help control that edema. Then we're looking to for stability in terms of our bandaging, and then also support. And kind of the support goes into our classic thought of why we're bandaging and splinting certain fractures. We want to immobilize that, and how we do that is by immobilizing a joint above and a joint below. Okay. These are my go-to supplies when doing bandaging. So definitely cast padding is number one. You want to have adequate amounts of that. Don't skimp on that. In the kind of, I guess, left corner or left side, there's Neopred-F. So this is more so for animals that are going to have prolonged bandaging, and they can get little cheesy toes, which we all know is just really, really smelly. I think that helps keep them a little bit dry. You could potentially use another powder, but it's just nice because it does have a couple other ingredients that help. You'll see me here. I have a couple videos of bandaging and what that looks like. We then have the cling wrap that goes over. And then vet wrap if we're bandaging. The press and seal and the cast padding or the casting material, the fiberglass cast, those are kind of add-ons, especially when we get into splinting. And I have a video of that as well. When we talk about a classic Robert Jones bandage, I would say probably I myself pretty much use modified Robert Joneses all the time. I can't remember the last time I probably used a Robert Jones in a horse patient. So that's how long ago that was. But a typical Robert Jones is 4 to 8 centimeters thick. However, in our patients, it can be pretty bulky and prevents movement. So most often we're going to do a modified Robert Jones, and then we're going to talk about reinforcing that Robert Jones bandage. So whether that's with our spoon splint or kind of classic quick splint, or one that we've made a fiberglass splint. I will do a bivalve cast. That does require a cast saw. Most of you probably don't have that. But if you do, sometimes a bivalve cast is pretty nice because it provides a circumferential stability. And then we can actually use one of the halves when we kind of downgrade that. So any questions on that? Does anybody use anything different that they really like? Paige? No? Okay.
Nope, we're good.
Okay. All right, cool. It is pretty standard. So here, I'm gonna take off the volume. And so here's just a quick video. This is typically what I do. We'll play it again. Nice little loop. And I pretty much squirt it in between all the toes. Occasionally, if they're getting sores in between their toes, I will place usually either like make small little like toe guards. I don't know if any of you get pedicures, but it kind of looks like that, but it's basically a little bit of telfa, and I just kind of snug them up in between the toes to make sure that we have a little bit of space. This is a patient that had a pantarsal arthrodesis, so a little bit different, but we definitely managed this in a half splint for quite a while.
Dr. Taylor?
Yes.
What are your thoughts on leaving toes exposed versus not?
So I tend to wrap to the most distal portion of the toes, and let's play this one. So I would prefer, nothing to create a tourniquet. So I like to wrap as distal as possible because that prevents any sort of stricture around that distal area. Does that make sense? So you'll see me wrapping here. The same patient, my stirrups could be better. You can use a tongue depressor. that is good. And this, I mean, this is a patient you can see he's a 6-year-old intact male. But typically aside, like we are on the ground, we try to get them as comfortable as possible, but he is not sedated. He hasn't needed to be sedated. So this is something they get pretty comfortable with, and you can, facilitate, frequent bandage changes. And we'll get into the frequency here in a little bit. Without much sedation. So I guess cutting down a little bit of cost for that owner and a little bit of time for you guys. But typically when I'm doing bandage changes, I will have people come at a specific time every week, and that's just their time slot, and we can get it done in about 15 to 20 minutes. But so you'll see here multiple layers of cast padding. He's getting a little cantankerous there, but I don't care. I know from the equine world, people sometimes care inside out or outside in. Just wrap the leg. I don't necessarily think it matters that much. And there actually was an equine study that said that, but equine people wouldn't appreciate that. Then what we're going to do, of this animal had a half splint. This one was already made. I'm going to show you a video upcoming of me making a splint. But this is how I typically do it. This was pre-made for him at surgery, trimmed up nicely. And then I will use the cling to attach it to the cast padding. And then we kind of get our stirrups. You'll be able to see how much of the toes or kind of lack thereof are exposed. And then we'll do vet wrap over that. And then one of my favorite products, which I didn't put in here, which is silly, but I'm happy to, send anybody to Amazon or their website, but is a Medipaw. It's a super amazing product, and it has like a rough bottom. I think I'm going to put it on this one. I'm not sure, but I'll figure it out after if not, but it's a Medipaw. It comes in different sizes, and it slips over the bottom. And so for any dog, again, that is going to be undergoing multiple bandage changes, it's a really nice way instead of an IV bag to keep it nice and clean. And it's pretty affordable for the owner. So here you go. Kind of a nice, I know a lot of times people want to like roll out their vet wrap, which I think is fine, but if you're using an adequate amount, oh yeah, I did. Perfect. So this is the Medipaw. If you're using an adequate amount of cast padding and you're not, snugging it tight, it should not constrict. You have plenty of padding underneath there to do that. So I don't think that you need to unravel and re-ravel. But yeah, so this is the Medipaw. It's got a really nice, I'm using it. Is there a pointer? Can I point on this? Is that it? Here, can you guys see that?
Yes.
Okay, so it has a really nice kind of tire bottom to it, so it creates a lot of traction, and then this typically just slips over. So that's a nice one. All right, next one is, okay, so this is a different patient. I've been running a special on tarsi these days, and this was is a partial tarsal arthrodesis. So I'm going to make this one a splint. This is very easy, pretty much the press and seal. So you're going to kind of do the majority of the bandage. So you're going to do cast padding and cling. The first bandage is always going to have a separate or a second layer of cling over the cast because you want to make sure that the bandage is at least fairly tight from the cast padding when you apply your splint. Hopefully that makes sense. But all you're going to do is basically accordion. So you're going to get the casting material, the fiberglass wet, and you're going to just do this accordion. A lot of times I'll have an assistant also gloved up that's helping me at least potentially hold the top or the bottom. So it's as long as I want it to be. This is a really great tool. And so you do a few layers. I think you pretty much kind of gauge how thick you want it to be, how much support you need it to be, and then you're going to kind of mold it. And at this point, oftentimes I'll keep dipping my hand in some water, warm water, until it sets, until you get a nice mold. Then once it kind of sets, you're going to literally peel it off the press and seal. And then you see these scissors down here, which I stopped the video, but then you're going to trim it up. And then the next video is going to show kind of what it looks like trimmed. I guess in addition to this, so this is a hind leg, so we're kind of molding it around the hock. It's a really nice way to do it. I always find the quick splints are, if they're wide enough, they're too long or they're too short, or it just doesn't fit. I think you can sometimes customize those as well. So you might be able to trim those. Nail trimmers work really well kind of in those grooves. But overall, I find this to be a lot easier, especially if you're kind of doing a workup for the first time. You've gotten your radiographs, whether or not you're going to, send or not send it for surgical fixation. You can do this kind of at the same time under the same sedation. Here, we're going to do a lateral splint, more on the forelimb. We're going to do a more caudal splint. So if you're doing it for kind of radius ulna, the nice part, you can kind of mold it caudally so it gets really good stabilization. Any questions there?
No, actually, well, there's one.
Yeah.
Do you leave the Medipa on all the time?
I do not. That's a great question. Thank you for asking that. I do not. So I typically tell people that the majority of the day, like when they're getting up and kind of moving around, yes, I like them to have the traction, and also when they're going in and out of the house. If they're in the house, though, it does not have to be on, but it is fairly easy to put on and off. So I haven't had anybody complain about that. But typically, if somebody wants to leave it on the majority of the day, I make sure that they're sleeping out of it.
Yeah. We did provide a link to the medipaw.com too.
Oh, wow. Oh, cool.
Yeah.
Thanks. I do not work with them. I have no whatever, but they're one of my favorite products. I can give anybody the other ones as well, but Help Them Up Harness, that one's on there. So I can easily give referrals for that. Okay, and then this is the kind of finished product. So this is after cutting. I probably could have shown you trimming it, but pretty much it's molded. I've trimmed the edges, rounded the edges, softened it. If you have, a nail, like a Dremel, if you feel like you've got sharp edges, you can definitely Dremel it down. You can cut it to size. So it shouldn't be so thick that you can't manipulate it. And you want to make sure that you take it off just in time before it gets super duper hard. Even if that's the case, if for some reason you're like, oh darn, I've, made it and I don't like that, then it's not impossible to cut when it's hard. Sometimes I'll have a patient come in and I'm not super happy with how they're wearing it, or the bandage just doesn't seem right. I can sometimes trim it at that point too, or you can always make another one. All right, so now we're going to kind of hammer through some more examples, okay? So we're going to talk about which fractures we can stabilize, which fractures we absolutely can't, and kind of those in-between ones. So we're going to work through like metabone fractures, we're going to work through radius ulna, humerus, tibia, fibula, femur, and then pelvis, everybody's favorite. But please feel free if you have any questions when we go through these to ask. So metabone fractures, not entirely uncommon. I would say these are kind of two different ways that we see them. You can see definitely the one on the right, clearly kind of fairly displaced, multiple fractures, probably one you may think more about, oh goodness, do I need to surgically refer this for surgery? And then we get more of these, I would say, non-displaced transverse ones, non-articular, that you probably can manage yourself in a spoon splint. So typically when we talk about surgical guidelines, we're talking in our head, and these are not hard and fast. I think they're talked about in the surgery textbooks, but there's definitely factors that weigh into each of them. So more than 2 metabone fractures, I would say that's probably not a hard and fast. The fracture on the right definitely had 3 fractured, and we didn't do surgery there. But then fractures involving both the primary weight bearing bones, that's 3 and 4. Maybe we think about surgery there. Articular, probably another conversation as well, or talking about what the sequelae of that is with the owners in terms of arthritis. If the fragments are displaced by greater than 50%, again, when we look at the slide before, definitely one that we're probably going to think more about surgery and less about conservative management. This one's a little bit different. That involves a base of 2 or 5. I've definitely left those alone. So take it as you will. And then again, large breed or athletic or working, show dogs. Again, we want to surgical stabilization is oftentimes going to return to alignment and weight bearing in a shorter amount of time than if we manage these. A little caveat to this is that metabone fractures are notoriously annoying to heal, even when we surgically stabilize them. So this is an example of how we surgically stabilize them. We typically do this dowel pinning or kind of intramedullary pinning. I still will place these animals in a splint for probably about 4 weeks post-surgery. And that's because we don't have rotational stability with this repair. And oftentimes, if we plated these, we don't plate these on dogs that can't take a very small plate. So sometimes we're just limited in what we can do. But I think spoon splints are great. I typically would make my own spoon splint with the casting material, similar to this, but just a little bit of a lip on the bottom. These are kind of 2 more recent papers on what kind of the healing of metabone fractures. The Von Field paper was more recent, and that was a minimally invasive. We'll talk a little bit about that fluoroscopy pinning technique that they showed some pretty decent success with. And then Kornmeyer in 2014, they actually did a little bit of a comparison of surgical repair versus conservative management versus a mix. So some of the metabones they didn't fix, and then some they did surgically stabilize, and looked at the complication rate and the outcomes. And in that paper, they didn't necessarily see that much of a difference, even between complication rate and those differing between surgery and conservative management. So I definitely think this is one of those types of fractures that, if the owners are absolutely all in, send them. We want to fix them because it does help them. But I think in the long run, they will heal and they will do fairly well with conservative management. So you guys can be splinting these and managing these in your practices. Might be a good idea to talk about intervals of splinting. I think I have that somewhere. But I typically do at weekly intervals. So I don't want these definitely in a puppy, but I even don't want animals wearing a splint for longer than 7 days, only because it helps me monitor them. I'm less likely to get any complication and less likely for it to fall off. So those are the things that I like to do. I would probably definitely not let it go more than 7 days. All right, any questions on metabone fractures? Perfect. Cruising right along. Oh my goodness, radius ulna. So usually either hit by car versus a fall. I would say radius ulna in terms of if there is a significant amount of trauma, more likely to be an open fracture, one that we may consider starting on antibiotics when we're doing it. This is definitely a fracture that we can bandage and splint in the meantime while waiting for surgery. I will caution everybody on, these small toy breed dogs. I think this is a very, very common fracture. They've jumped down and all of a sudden, or someone has stepped on them, they got caught in a recliner. That one's a good one. So we want to fix these toy breed dogs have a different vascular supply. This is a very kind of old paper, but one that is rings very, very true. So there's definitely a different vascular density of the distal radius in a toy and small breed dog versus a large breed dog. And you can see here, so B is a large breed dog, and you can see just the vascular network in terms of the more blackened area versus this toy breed dog where we're looking at much less vascularity. They don't heal well, even if they're non-displaced or minimally displaced. I've seen, seen these fractures for 6 weeks of bandaging and we're getting no healing. And the reason why is they're just not stable enough and they don't have the good blood supply. So we need to create that stability with an internal fixation in order to allow time for that vascular supply to come in and help heal that fracture. Terrible picture all the way on the left, but the lateral is a little bit bigger. This is one of those cases that I'm talking about. So 6 weeks later, and we have this. Essentially, I'm having to re-break this bone and create some stability. So, and also kind of encourage a blood supply, whether that's a bone graft, whether that's what we call osteostasis, again, something you don't need to know, but it's a much different repair than something that comes in a little bit more acutely, like the repair that's on the right here. So pretty straightforward radius ulnar repair. And this should heal in about, depending on the age of the animal, typically about 6 to 8 weeks. I typically tell my puppies, so if we're having open growth plates, we're more at the 6-week mark, and adult dogs, we go 8 weeks for bone healing. Questions on radius ulna? Okay, so moving right along to the humerus, my least favorite bone. It's not funny at all. So every time we see a cute little Frenchie, and I love Frenchies, I have a Frenchie, but I see humeral fractures. Humerus has a wide gamut of what we can do, but basically the humerus is not amenable, very, very minimally amenable to splinting and bandaging. A lot of times it will create a fulcrum at the area. We talk about, so there's a nice lateral condylar fracture, very typical for this breed, very typical age. You have all these open growth plates, very susceptible. So this is what I see when I see a Frenchie, except when I'm looking at my own. So things that we need to consider in terms of referral for this is, again, talking about that entire patient, the anatomy of the radial nerve. So the radial nerve crosses distolaterally, and then on the medial side, there's the median and ulnar nerve. So going back to the prior example of that Y fracture in the humerus, we're talking about potential for damage to both nerves, whether that's pre-surgery or even in surgery, we can have some more neuropraxia based on kind of manipulation. So assessing that nerve function is really, really important. Dogs versus cats, just remembering that cats have that supracondylar foramen. Again, we are not bandaging these. I would say maybe in a very kind of rare case, especially this dog, the one that's on, sorry, this dog that's on the left here is, I would say potentially you could do a spica splint if you feel comfortable doing that. I definitely would do the kind of handmade casting material. There are actually, there's a great YouTube on how to do that as well if you're not comfortable. I could also, if anybody wants to email me, I can show you a video. I have that as well, but there's not a huge usage for spica splints, I guess, in terms of fracture management, more so in terms of luxation, elbow luxation, which we're not covering here. So potentially in this case, but again, in something like a Y fracture or even a mid-diaphyseal humerus fracture, it's unlikely that that is going to create enough stability to help you out. So typically with these, refer them as soon as you get them, and we try to get them into surgery within a day or two because they are articular, or based on this, we do have open growth plates here, so we want to restore that normal growth as soon as possible. Just a little idea of what that looks like. All right, tibia, fibula. So more common in younger animals. We talk about growth plates. We'll go through Salter-Harris so you guys have an idea of when you're referring what that looks like. Again, concern for open fracture because of the lack of medial soft tissue. They are amenable to splinting and or kind of internal fixation. Again, we talk about the quick splint. I just don't have good luck with them. I hope that you guys do because that can be very helpful because they're prefabbed, but I prefer to make my own. All right, just a quick Salter-Harris scheme. Remember your P's. When we talk about type 1 versus type 2 versus type 3, if you count your P's, you'll get the scheme right every time. So Salter-Harris type 1, separation, so 1 P with the physis. When we talk about Salter-Harris type 2, we're going with physis and epiphysis, so 2 P's. Salter-Harris 3, no, sorry, metaphysis, my bad. I'm not counting my P's. And then when we talk about 3, that's gonna be physis and epiphysis. 4 is all 3 of them. And then 5 is a crushing injury. So that's a good way to remember it. So this is a pretty classic case here. Young puppy. So you can see wide open growth plates, very large hypophysis. So we're talking probably 10, 12 weeks, not uncommon. The nice part about this is if you can see here, this fibula is intact. I would say minimally displaced. This is definitely one that does not need surgical repair. So this is one that you could create a bandage and a splint and manage conservatively. This is going to heal very quickly. So probably only about 4 weeks. It's going to need 4 bandage changes. Keep them quiet, keep them medicated in terms of pain management and also sedatives. Don't skimp on the sedatives because they are puppies. This will heal very quickly. Here's an example of one. This was sent to me at 2 weeks. So this was 2 days post. There was some noticing something a little bit irregular, but the dog, they weren't quite sure what it was. Dog wasn't rested. And it came to me 2+ weeks later. This is the fracture. If you can even see how much growth he's had in 2 weeks, which is pretty significant. That is what it looks like. And then we had the conversation at that point. It was pretty stable. So I had the conversation with the owner. Do we continue with conservative management? I did place external coaptation. And then at 4 weeks, so I did that 2 weeks for 2 weeks. And this is what we had at 4 weeks. The dog did have a little bit of angular limb that was pretty static at that point. So just kind of a case of even if it doesn't look displaced or we're a little bit, we don't necessarily know, I'm always happy to look at radiographs. Please send them because we kind of want to avoid this. More classic diaphyseal fracture, obviously in a large dog, that's going to be surgically managed, but typically we do an intramedullary pin and plate with screws. Here's a very classic one. Sorry, I'm moving a little bit quickly because I want to get to everybody's favorite. We're probably just going to skip the femur and go to the pelvis. Growth plates, again, with the tibia fibula, so a tibial tuberosity avulsion fracture. I think there's a little bit of, this is kind of, sometimes we do, sometimes we don't. Granted, with this amount of displacement here, this is one that we do recommend surgery in. However, this is one that I manage conservatively. So yes, there is some separation here. Even here, there is a little bit separation and maybe a titch of shifting. Financial constraints or otherwise, we did manage this dog conservatively, and I did place this dog in an external bandage. I did not place it in a splint, but we rested it heavily, and by about 4 weeks, it was healed. This is how we fix it. I will say a cautionary tale for myself. These puppies grow super duper quickly. So you can see here, this was 4 weeks. And I don't love seeing this. So I've kind of shifted my practice, and now I will typically take these out in the younger population of dogs. If this happens in a 6-month-old animal, I probably won't take it out, but I kind of got burned on this one. Femur, most commonly fractured long bone, 3 parts. I guess maybe we won't skip it because it's got some good information. Sorry. So it definitely is one of the most commonly fractured long bones, typically high impact. We've got the proximal portion, the femoral head, with then with the diaphysis, and then the distal portion. This is one where we do see sometimes hypovolemic shock. We also see additional abdominal injury. So depending on the degree of trauma and what the fracture looks like, we are going to be evaluating this patient pretty closely. Proximal femur for everybody, which is why it's important. So we have this kind of extra osseous ring. That's super important in supplying the intracapsular and intraosseous. It is susceptible to injury. And additionally, dogs do not have any sort of contribution to their ligament of the head of the femur in terms of vascular supply, which is why they get avascular necrosis. We're going to just skip through these cases, but they're pretty classic. So proximally, if we can get a capital physeal fracture, we typically will do an FHO. This dog FHO'd itself, but even subtle changes here. So be on the lookout for that. More common, that's it. And then distal femur. Any questions on femur, I guess, before we get to pelvis? Oh my goodness, I'm talking so much. So pelvis, super important because we have quite a bit of intra-abdominal trauma or other structures or other organs that are. This is both these are critical care papers in 2016. 40% of dogs had intra-abdominal trauma. Gant, 20% of cats with pelvic trauma required a transfusion. So again, your minimum database may be a little bit different in these patients. They also are patients and owners need to be prepared that there is a potential for these animals to need much more stabilization prior to even obtaining radiographs. Then we talk about, again, the neurological status with the sacrum, the SI joint. So surgically, typically we talk about anything cranial, we're going to fix anything with a greater than 50% narrowing of the canal. I would say as long as they're able to poop and they're not breeding bitches, that 50 is probably a little bit up for interpretation. We do restore alignment and weight bearing. Non-surgical, we talk about ischium pubis and even some of those caudal acetabular ones. So the weight bearing surface of the femur within the acetabulum is that cranial kind of 1 to 2/3. So even kind of half, I guess. So in those more caudal fractures, even still, they may look ugly, but we're not going to fix them. Also non-surgical, kind of these highly comminuted fractures. This is where imaging gets kind of important and multiple views and potentially a CT, but this is a patient that there's an iliac body fracture here. But there's a little bit of question as what's happening here in the acetabulum. But if you kind of look at the orthogonal view and these are offset, this is a little bit oblique, that you see that the cranial portion is still intact. So we feel pretty good about just doing a simple repair of that iliac body. And this is sacroiliac luxation in a cat. And you can see here this large step defect. This cat, there's also some separation here. This cat was non-ambulatory and very neurologically compromised. A shout out to our new fluoro machine. And so we now have the ability to do this fluoroscopically, which is really, really amazing. But you can see here, this was my first attempt at reduction, not very great. And this was my second attempt. So you see we're much more aligned. Then we're going to go ahead and stabilize that with a transilial rod. This is this crushed pelvis. So a couple options for this this patient was pretty financially constrained. So after stabilization, which it needed quite a bit of based on these radiographs, the owner's options were to kind of go all the way, potentially do a CT, and then fix the portion of the ileal body, plus or minus what is left of the acetabulum if we could, and then we're going to leave these caudal fractures alone. Alternatively, what they elected is we actually did conservative management. Even though there's a decent amount of displacement here, the animal was able to urinate, defecate, and we managed conservatively. And this patient is probably going to come in the next few weeks and have an FHO. So the articular nature of this is probably what is still causing this patient a little bit of discomfort. But if we were to do an FHO in this case, we would be okay. Okay, quick note on, and then I'm gonna take questions. Oh, good, 7:50. So again, communication with our team, with your team. I am always happy to take a call if you guys have a question about a fracture. It might be hard to get me on the phone. Leave me a message. I'm absolutely happy to call you if you have a question. Please send radiographs, and please take orthogonal views. Sedate your patients, make sure we have radiographs, because it totally changes. Some fractures we can fix for, $4,500. Other fractures, I can't even get there. So that's going to be $8,000-9,000. And that largely depends on what the radiographs look like. And so I want to make sure that, clients are we're just informed, and that's a big thing. And I can't do anything for $2,000. I wish I could fix every fracture for free. That's just not the reality. So just making sure that everybody is set up for success, especially in those polytrauma cases. And then always feel free to email me rads, call me, whatever. Happy to take questions. These are all my babies, so my fur babies, Roger and Boris. And then these are my twins, who will be 2 in 3 weeks. So if I don't take your call, I'm with them. And then shout out to the guy in the middle who helps me with bedtime every night, and especially when I'm not at home, because it's a lot. So I'm happy to open the floor for questions.
Great. Thank you, Dr. Taylor. This has been very informative and very helpful. One question is, the video that you had of the bandaging.
Yeah.
Would you be able to share that, and we could send it with the CE certificates that we send out?
Yeah, absolutely. Okay, I can take a better one. I should probably take a better one too, but yes, I can easily get you at all of that.
Great. Well, thank you. That would be very helpful for a reference when we're going, what did she say? What did she have?
Yeah.
Another question is, how often do you see neurological deficits with these fractures, and does it ever concern you that the patient won't improve after?
Great question. So how often do I see neurological deficits? I would say with pelvic trauma, much more common than with humeral trauma. I think that the radial nerve is fairly protected, even though we worry about it. Gosh, percentage wise, I would say there is some degree of deficits, especially when we're talking about an SI luxation, and probably about 70% of the cases. Now, the biggest thing is to make sure that we're testing both superficial and deep pain. If these patients maintain deep pain, even if they don't recover fully, they will most likely have motor function of that leg. I think that's the big take home, is that check that deep pain. Just squeeze on those toes. I know they're painful, but that is super duper important.
Great, thank you. Does anybody have any additional questions? If you do, go ahead and enter them into the chat. Oh, let me see, there might be one. Hold on. Oh, somebody says thank you.
You're welcome.
Again, for those that have joined a little bit late, we will be sending the CE certificate out to the email that you signed up with, and we'll include a bandaging video with that email. And I think that might be, just double check one more time, scroll through. Yep, I think that might be what we have for today. Thank you so much, Dr. Taylor. This is really helpful.
Yeah, absolutely. Anytime. And we really appreciate, or I really appreciate, all the referrals, and I'm happy to speak with whomever, whenever.
Awesome. Thank you, everybody. Have a good night.
Thank you.